Biographical Bytes from Bala, Laurel Hill West Stories number 46 for mid-July 2025. Dr. Robert A. Groff, Cutting Brains. Welcome to the 46th episode of Biographical Bytes from Bala, Laurel Hill West Stories, an historic and active cemetery in Bala, Kenwood, Pennsylvania. I am Dr. Joe Lex, retired professor of emergency medicine from Temple University, volunteer tour guide, and volunteer podcaster. I am recording this on July 5th of 2025. Laurel Hill West opened in 1869. Across the river from its sister cemetery Laurel Hill East in Philadelphia. It's more than twice as big as Laurel Hill East. It has a totally different feel, a strikingly different population. Laurel Hill East is Victorian, associated with the Civil War. Laurel Hill West is more Edwardian, associated with the Great War. Like Laurel Hill East, it is open 365 days a year, now from 7 a.m. to 7 p.m. There is plenty of parking at the business office just off Belmont Avenue or at the conservatory and the bell tower. If you enter from Belmont, follow the road past the second gate with the white line in the middle. Another possibility is to come in while you're walking the Kenwood Trail. The mid-July 2025 podcast was supposed to be about newspaper reporter and AIDS activist Ronald Boyd. I found scanty information on him. Maybe I'm not looking in the right place. I didn't get to dive real deep, but for the sake of having something that I knew I could get done, I switched to Philadelphia neurosurgeon Robert A. Groff. He was one of the last American practitioners to perform the disabling procedure of lobotomy. I will talk about what led to the belief that by injuring healthy brain tissue, it could be beneficial to many people. I'll talk about another Philadelphia-born and trained practitioner named Walter Freeman, who became the drum major for lobotomy. He drove around the country in a lobotomobile, and he carried an ice pick in his pocket, quote, just in case. And late in his career, Dr. Groff was sued by a patient who did not like his results. But the doctor died before the case came to trial. With very rare exceptions, lobotomy has now gone the way of bloodletting and spiritualism. Let's hear about lobotomy and Dr. Groff. Robert A. Groff, M.D., brain cutter. There was a curious case report published in the January 1849 issue of the Buffalo Medical Journal and Monthly Review of Medical Surgical Science. Dr. John Martin Harlow, 1844 graduate of Jefferson Medical College in Philadelphia, practicing in Cavendish, Vermont, encountered the unfortunate railroad foreman Phineas P. Gage. The prior September, 25-year-old Gage had been preparing to blast some rock. He'd filled a hole with powder. He was tamping it into place, but he created a spark and that turned his tamping tool, some people have incorrectly called it a crowbar, into a high-speed javelin, 11 inches long, that tapers to a 1/4 inch at the point. The powder exploded. The iron bar rocketed from the hole. It pierced the left side of Gage's face, going upward, just in front of the angle of his lower jaw. The iron rod continued upward outside his upper jaw. It probably fractured his cheekbone, zygomatic arch, but it passed behind his left eye, through the left side of his brain, and then shot completely out of the top of his skull through the frontal bone. The tamping iron landed point first, some 80 feet away, quote, smeared with blood and brain, end quote. Gage was thrown on his back. He had some convulsive movements of his arms and legs, but he soon woke up. He said a few words. With a little assistance, he walked. He sat upright in the ox cart that took him 3/4 of a mile back to his lodgings in town. Now, in addition to the ghastly head wound, he had deep powder burns on his face, hands, and forearms. About 30 minutes after the accident, physician Edward H. Williams found Gage sitting in a chair outside the hotel, and he was greeted by him with the statement, "Doctor, here's business enough for you." The doctor's report. I first noticed the wound upon the head before I alighted from my carriage, the pulsations of the brain being very distinct. The top of the head appeared somewhat like an inverted funnel, as if some wedge-shaped body had passed from below upward. Mr. Gage, during the time I was examining this wound, was relating the manner in which he was injured to the bystanders. I did not believe Mr. Gage's statement at the time, but thought he was deceived. Mr. Gage persisted in saying that the bar went through his head. Mr. G got up and vomited. The effect of vomiting pressed out about half a teacup full of brain through the exit hole at the top of his skull, and that fell on the floor. I'm going to interject here that from my 30 years of working emergency departments in and around Philadelphia, I can verify the consistency of living brain tissue is about like that of toothpaste. It will squeeze out of skull defects when it's placed under pressure. Now, Phineas Gage became a fixture in the curricula of neurology, psychology, and neuroscience, a living part of the medical folklore. He is frequently mentioned in books and scientific papers for the hole in his head, just as the French-Canadian trapper-hunter Alexis St. Martin and the hole in his stomach. Gage is remembered because his case may have been the first to suggest the brain's role in determining personality, and that damage to specific parts of the brain might induce specific personality changes. Dr. Harlow did not know Gage prior to the injury, but described him as, quote, a perfectly healthy, strong, and active young man, 25 years of age, nervobilious temperament, 5 feet 6 inches in height, average weight 150 pounds, possessing an iron will as well as an iron frame. That term nervobilious was curious. I'd not encountered that before. That came from the pseudoscience of phrenology. Phrenology was just about ending its vogue at this time. Nervobilious denotes an unusual combination of excitable and active mental powers with energy and strength of mind and body, making possible the endurance of great mental and physical labor. Perfect laborer, in other words. Gage's purported personality changes after the trauma were commemorated in a limerick. A moral man, Phineas Gage, tamping powder down holes for his wage, blew his special-made probe through his left frontal lobe. Now he drinks, swears, and flies in a rage. Medical mythology tells us that Gage became a different man, a wastrel, a drunk, a wife-beater, a thief, an amoral mountebank. None of these behaviors are mentioned by anyone who ever met Phineas Gage or even his family. And Dr. Harlow never recorded any event that Gage would be ashamed of. And as far as wife-beating, well, Gage never married. Gage's convalescence was long, difficult, and uneven. Harlow carefully handled his prized patient. I was taken aback when I read how Harlow, quote, cut off the fungi which were sprouting out from the top of the brain, end quote. Looked it up, had a different meaning back then. Fungus he talked about was an old term for deteriorated or dead and infected tissue. In other words, this was standard wound debridement. As the old wound died and started to slough, he trimmed it away. Gage lived for several years after his injury, but he did die at age 36 with unremitting seizures, so he lasted about a decade. While it is certain that his personality changed post-accident, the reliability of reports varies. His skull and the tamping tool both are usually on display at the Warren Anatomical Museum at Harvard University that had been established in 1816. Trepanning, the practice of making a hole in the skull for medical purposes, dates to the Neolithic period. That's 10,000 to 2000 BCE. There's an archaeological site in France from 6500 BC that reveals 120 skulls. 40 of the skulls show evidence that they had undergone trepanning. Now, this makes it the oldest surgery with anatomical evidence. Now, how do we know these holes were not drilled post-mortem? Because about 40% of the individuals showed signs of bone healing after the surgery. So that means about 2 in 5 survived having holes drilled in their head back 6500 BCE. Ancient Rome in the 1st century AD had its brain surgery star, Celsus. Hippocrates did not operate on depressed skull fractures. Celsus often did. Celsus also described the symptoms of brain injury in great detail. Trepanning was mainly used after head trauma to elevate the bone and remove fragments of tissue, bone, brain, foreign body, foreign material. But sometimes trepanning was performed to release evil spirits. By the late Middle Ages, this practice was so common that Dutch painter Hieronymus Bosch depicted it in his painting, The Extraction of the Stone of Madness, which you can see at the Prado Museum in Madrid. I talked about this painting in an earlier podcast about Thomas Story Kirkbride and his architecture for the insane. On August 4th, 1875, Richard Caton reported to the British Medical Association in Edinburgh that he had used a galvanometer and observed electrical impulses from the surfaces of living brains in a rabbit and a monkey. Now, this led to the discovery of alpha waves and eventually to the use of implantable electronic devices like cochlear implants, deep brain stimulators. The ability to cut into the brain was limited until there were 4 major breakthroughs in the 19th century. Anesthesia, prevent pain. Antisepsis, prevent infection. Hemostasis, prevent exsanguination, prevent bleeding to death. And imaging. In 1879, Scottish surgeon William McEwen was the first person we know of to successfully remove a brain tumor, which he had diagnosed strictly by physical exam. This is 16 years before Röntgen described radiography. McEwen used a trepanation technique. It was not until 5 years later that the English surgeon Rickman Godley used an open skull technique in which he actually visualized the brain to remove a tumor. Brain surgery was initially limited to repair damage after trauma and the rare tumor removal. Researchers had been mapping the brain for centuries to identify the role of each segment. The idea of intentionally damaging organically healthy tissue was anathema to many clinicians. But, as it usually does, the technological imperative won out. Once it is possible to perform a task, then we will look for ways to perform that task. It's the old adage, when your only tool is a hammer, everything starts to look like a nail. Quiet experiments were being performed on patients in asylums around the world during the last part of the 19th century and the first part of the 20th century. And in late 1935, it was Portuguese neurologist, not neurosurgeon or psychiatrist, Antonio Igaz Moniz, who with neurosurgeon Pedro Almeida Lima, named and started to perform psychosurgery. Their first operations involved injections of alcohol into the frontal lobes of patients to destroy the white matter. Moniz then devised an instrument he called a leucotome to remove small cores of white matter. He coined the term leucotomy, a hole puncher for the brain. Moniz's methods were adopted in the United States by a neurological team led by Philadelphia-born and University of Pennsylvania-trained neurologist Walter Jackson Freeman, along with neurosurgeon James Watts. Initially, Freeman and Watts utilized Moniz's original technique. They subsequently developed their own method, which more thoroughly severed the connections between the frontal lobes and the deep brain structures. They introduced the term lobotomy for this procedure. This became recognized as the standard prefrontal lobotomy or leucotomy associated with Freeman and Watts. Collectively, they performed approximately 600 of these procedures. The standard lobotomy or leucotomy involved drilling holes in the skull and inserting a cutting tool without direct visibility, which made it a closed procedure. In 1937, J.G. Lyerly introduced an open technique when he accessed the brain through larger forehead openings. This method allowed surgeons to see what they were cutting, and it became preferred for its reduced risk of blood vessel damage, and soon the open technique was the predominant approach in the United States. The use of psychosurgery expanded in the 1940s with the development of various operative techniques. In 1946, Freeman introduced the transorbital lobotomy, a procedure in which an ice pick-like tool is inserted under the upper eyelid above the eyeball, passed through the bone with a mallet, and then moved side to sever organically healthy white matter. Electroconvulsive therapy replaced traditional anesthesia during this operation, which Freeman conducted without a neurosurgeon. Now, this resulted in professional disagreements with Watts, but the non-surgically trained Freeman conducted more than 4,000 transorbital procedures in his career, including on children as young as 4 years old. Freeman became such a zealot for the procedure. He would travel around the country in his lobotomobile, and he would perform demonstration procedures. Freeman carried an ice pick in his pocket just in case, and once he performed the procedure in a motel room. In 1951, one of Freeman's patients at Iowa's Cherokee Mental Health Institute died when he suddenly stopped for a photo during the procedure, and the orbitoclast accidentally penetrated too far into the patient's brain. In fact, it's estimated that as many as 1 in 7 of Freeman's patients died because of the technique, which he had turned into an office outpatient procedure. In other words, it is entirely possible. Let's see, 1 in 7, 4,000 procedures. That means Dr. Walter Freeman may have killed as many as 300 of his patients in a procedure that was not proven to give much improvement. Also during the 1940s, other neurosurgeons devised their unique methods of psychosurgery in an attempt to cut down on the sometimes horrendous side effects. Precision cutting of anterior capsulotomy, cingulotomy, subcaudate tractotomy, amygdalotomy, limbic leucotomy, all offered similar results, both positive and negative. The 1940s also saw the introduction of the stereotactic frame. This let surgeons find their bearings more accurately when they did closed operations. In 1949, Moniz shared the Nobel Prize in Physiology or Medicine because of his, quote, discovery of the therapeutic value of leucotomy in certain psychoses, end quote. Now, by this time, the technique was falling out of favor. Effective psychotropic medications were cautiously being introduced to treat severe psychoses, and they seem to be working. Remember that before the mid-1950s, psychiatric medicine primarily involved psychotherapy, which has limited effectiveness for individuals with severe psychosis. It's hard to reason with people whose reasoning is broken. And what else was available were shock therapies using electricity or insulin or chemically induced convulsions. Many patients spent extended periods in state institutions that were inadequately managed. Physicians who worked with these patients frequently faced significant challenges. During this period, lobotomy was introduced as a treatment option, and it was occasionally reported to help some patients return to daily life, including roles such as parents, professionals, community members. In cases described by Freeman as successful, patients experienced a shift from severe symptoms such as suicidal thoughts and deep depression to outcomes like reduced motivation, lack of foresight, effects associated with changes to the frontal lobes. Lobotomy was deemed successful in a woman if she could return home, adopt feminine norms of behavior, and bear children. Later, negative stories appeared that portrayed men whose masculinity was damaged by lobotomization and who became overly docile or childlike after the procedure. Now, contrary to some reports, Freeman's lobotomies did not involve removing sections of the brain. Freeman was less willing to share his failures. On average, the lobotomist sliced an area of brain equal to the cross-section of an orange. Not surprisingly, many patients developed disturbing side effects, apathy, inappropriate social behavior, infatuation with their own toilet habits. They told pointless jokes. They exhibited poor hygiene. Did they become zombies like we see in movies like One Flew Over the Cuckoo's Nest? Well, unfortunately, that was not an uncommon result. Walter Freeman's most famous patient was Rose Marie Kennedy, whom the family called Rosemary. She was born in 1918, the year after her brother John. The delivering physician was detained as he was caring for victims of the influenza epidemic, so Rosemary's birth was delayed by a few hours, which may have led to early oxygen deprivation. Her development was slow. By 2 years, she had a hard time sitting up, crawling. She was trying to learn to walk. When she was 11 years old, Rosemary was sent to a Pennsylvania boarding school for people with learning difficulties. At age 16, she was educated privately by 2 nuns and a special teacher. They elevated her skills to 4th grade reading level. She could read children's books, and she kept a diary. And while her father, Joseph Kennedy Sr., served as ambassador of the United States of America to the court of St. James's, Rosemary was presented as a debutante to King George VI and Queen Elizabeth at Buckingham Palace, although she practically fell over during her well-practiced curtsy. She accompanied her family to the coronation of Pope Pius XII in 1939. But when she came back to the United States from the UK in 1940, Rosemary started to exhibit increasingly erratic and challenging behaviors. She experienced frequent seizures, displayed episodes of aggression that occasionally resulted in harm to others. Rosemary also attempted to leave the convent at night, which prompted concern among the nuns regarding her well-being and possible associations. Her father became concerned that these developments might bring unwanted attention to the family and potentially impact their public reputation and political aspirations. When Rosemary was 23 years old, doctors suggested to Joe Sr. that Rosemary would benefit from lobotomy. He approved the surgery. He never discussed it with his wife Rose or his adult children. And the procedure took place in November 1941. Dr. Watts, the neurosurgeon, later recalled, "We went through the top of the head. I think she was awake. She had a mild tranquilizer. I made a surgical incision in the brain through the skull. It was near the front. It was on both sides. We just made a small incision, no more than an inch." The instrument that Dr. Watts used looked like a butter knife. He swung it up and down to cut brain tissue. "We put an instrument inside," he said. As Dr. Watts cut, Dr. Freeman asked Rosemary some questions. For example, he asked her to recite the Lord's Prayer, or sing God Bless America, or count backward. We made an estimate on how far to cut based on how she responded. When Rosemary started to speak incoherently, they stopped. Rosemary was kept separate from her family. Her mother did not visit for the first 20 years she was institutionalized, and her father never visited. None of her siblings even knew where she was for 20 years. They were informed only after Joe Sr.'s 1961 stroke, which left him mute. And when the family did talk about Rosemary, they described her as retarded and institutionalized, rather than as a spirited young woman with some behavior issues whose life was lost to lobotomy. After her father died in 1969, Rosemary Kennedy was gradually included in family activities again. Sometimes she visited relatives in Florida, sometimes in Washington, D.C., and she'd even go to her childhood home on Cape Cod, Massachusetts. And by this time, she was able to walk with a limp, but her speech stayed unclear. She had a palsied arm, usually in a sling. Her experiences have occasionally been cited as a factor that influenced her sister Eunice's decision to found the Special Olympics in 1968. But in a 1995 interview with the New York Times, Eunice clarified that Rosemary Kennedy was one of only several individuals with disabilities who would visit her home to swim, and emphasized that the games should not be attributed to any single individual. When Rosemary died at age 86, 63 years after part of her brain was cut away, in 2005, she was buried beside her parents in Brookline, Massachusetts. And I double-checked on this one because despite what is common knowledge about the actress Frances Farmer undergoing a lobotomy, there is no evidence that she ever underwent the procedure. And while Dr. Walter Freeman's parents are buried at Woodland Cemetery, he is interred in California. One of the last people in Philadelphia to perform psychosurgery was neurosurgeon Robert Armand Groff, 1903-1975, longtime chair of neurosurgery at the University of Pennsylvania. Groff came from a family of physicians. His father, Henry Groff, 1876-1968, was one of the first staff members at Temple University Hospital and founder of the Department of Radiology. He was a 1902 graduate of the University of Pennsylvania Medical School. Robert's grandfather was also a physician. Like his father, and like Walter Freeman, Robert was a graduate of University of Pennsylvania Med. He interned at UPenn Hospital from 1928 to 1930, was resident at the Graduate Hospital from 1930 to 31. He got a coveted slot at Peter Bent Brigham Hospital as a volunteer assistant to the American father of neurosurgery, Harvey Cushing, in 1931 and 32. 1934, he was resident under Charles H. Frazier at the University of Pennsylvania Hospital. He certified in neurology in 1937 and neurosurgery in 1940. This was at the height of the leucotomy-lobotomy period. During World War II, Dr. Groff was part of the University of Pennsylvania's 20th General Hospital under the leadership of Penn surgeon General Isidore Ravden in the China-Burma-India Theater. And much of what we know about the 20th General and the CBI Theater comes from a diary that Groff kept. It's now in the archives at Penn. We're going to start on May 15th, 1942. 64 doctors and 120 nurses from the hospital of the University of Pennsylvania gathered at 30th Street Station to board trains to Camp Claiborne Training Facility in Louisiana. Groff describes day after day of military foot drills under the hot sun. His entry for June 24, 1942, conveys unusual excitement. At 1:15, prepared for movies, and we saw a skit on sex and personal hygiene, and another film on the results of letting out information which is secret. He also soon tired of saluting. I might say that one almost wears out the arm in Alexandria. The number of enlisted men versus officers must be 100 to 1. Unfortunately, the heat and the boredom did not let up when the doctors and nurses boarded ships in Long Beach, California, January 19, 1943, for destination unknown. On the high seas, their accommodations became more uncomfortable, as Dr. Groff recorded in his diary. We have allotted ourselves one shower every 5 days. Water is like platinum. We are already beginning to smell like a sweatbox. In addition, deck space was limited, and a rotation was set for time on deck in the fresh air. A wartime crossing had other restrictions. All lights in our room go out, so that we have to dress and undress in the dark. We're allowed out on deck until 10 o'clock p.m., but no smoking is allowed after orders for darkened ship goes into effect. Groff served overseas for 33 months, during which time he was chief of neurosurgery and operated on more than 200 patients with head injuries, 100 spinal injuries, and 400 peripheral nerve injuries. By August 1st, 1945, the 20th General had admitted a total of 50,232 patients, of which 65% were American. In addition, the 20th treated 325 Japanese prisoners of war and a small number of British casualties. Despite the best efforts of the medical staff, there were 529 deaths at the hospital, 179 American, 329 Chinese, and 22 Japanese POWs. Of the American deaths, 66 were from disease, 88 from non-battle injuries, and 25 from battle casualties. You could hear more about General Ravden and the 20th General Hospital in Biographical Bytes from Bala, Laurel Hill West Stories number 26. After the war, Dr. Robert A. Groff had privileges to perform neurosurgery at Graduate, Pennsylvania, Presbyterian, and several other hospitals. He served as chair of the department from 1957 to 68, and he published more than 50 articles in his field. In 1963, he was installed as the first Charles Harrison Fraser Professor of Neurosurgery at the University of Pennsylvania. At the time that he practiced neurosurgery, the surgical destruction of organically healthy brain tissue was considered a helpful operation by many, and even standard of care by some. On December 1st, 1975, half a century ago, there was an article in the Philadelphia Inquirer called Psychosurgery, A Mind Can Be Altered. The reporter, Mary Walton, was following a court case. I'm going to skip around in this. Stanley Chase was 28 years old when he had his first lobotomy. He had another at age 30 and a third at 32. A lobotomy is an operation in which the connection in the frontal lobe of the brain that controls a human's high faculties, reason, planning, intellect, are severed with a blunt instrument. Chase had his operation to relieve anxiety and depression. Today at age 39, Stanley Chase, who once played the drums, is paralyzed on his right side. He had been reduced from bright normal on intelligence tests to borderline mental defective. He suffers epileptic convulsions, and his hydrocephalus, water on the brain, is slowly eroding his remaining abilities. He has no sense of smell and can barely taste. And, he says, the anxiety and depression that first caused him to go under the knife is more here now than it was before. So Stanley Chase is suing. His court case could be a landmark in the unmapped legal medical field of psychosurgery. It is first in a flurry of psychosurgery malpractice suits to go to trial, and is also part of a larger movement toward putting legal restraints on the medical field of behavior control. Chase's story is told in a mounting stack of transcripts in U.S. District Court here, where a jury has been hearing testimony since September 29th in a $10 million malpractice suit brought in connection with the last two lobotomies. Chase's suit charges the late Dr. Robert A. Groff, former chairman of the neurosurgery department at the Hospital of the University of Pennsylvania, with performing irreversible, dangerous, experimental surgery without obtaining Chase's informed consent, his complete medical records, or a thorough medical and neurological exam. Dr. Groff died of lung cancer in April at the age of 71, 9 months after the suit was filed. A videotaped deposition taken before his death has been shown in court. Chase's difficulties began when he was a youth in Brooklyn, where he grew up, the only child of parents whose troubled marriage eventually failed. His father, Joseph, a Polish immigrant who earned his living as a carpenter, was away from home much of the time. His mother, Clara, was overprotective and, according to observers, more than a little neurotic herself. Chase was a sensitive, overweight boy whose interests were literature and music. He could play a number of instruments, including piano, drums, and xylophone. As Chase tells it now in halting and stiffly constructed speech, interrupted by oddly spaced laughs, the event that triggered his psychiatric treatments was a film on cancer. Chase became obsessed with the idea that he had cancer. While still a teenager, he was diagnosed as schizophrenic, and he underwent a half a dozen electroshock treatments and roughly 50 insulin shock treatments in which heavy doses of insulin are used to place the brain in a coma. I'm going to insert my own editorial comment here. Insulin shock therapy, insulin coma therapy, was a form of psychiatric treatment which just sounds grotesque and brutal in retrospect. Patients were repeatedly injected with large doses of insulin to put them into hypoglycemic shock, to intentionally induce a coma. And this happened every day over several weeks. This was considered some sort of a hard reboot for the brain. Of course, that terminology didn't exist back then, but it would cause some sort of a reset of the brain by shutting it off and then letting it come back on again. ECT, electroconvulsive therapy, goes back to at least the 16th century when electricity was used to treat psychiatric illnesses. In fact, Egyptians have actually been documented using electric eels to treat headaches. I witnessed ECT. I witnessed electroconvulsive therapy a few times when I was in the Army. This would have been 1967. Valley Forge General Hospital, Phoenixville, Pennsylvania, 1967. The patient was taken to a treatment room and made comfortable. We put a bite block in her mouth, and then she had electricity shot through her brain with an electrode that was strapped to each temple. This caused the immediate tonus-clonus of a seizure. First, if you activate all the muscles in the body at once, the extensors are stronger. So when all of the muscles contract simultaneously, the extensor muscles overwhelm the flexors, sometimes to the point that the only body parts that are touching the stretcher are the back of the head and the heels. This position is called opisthotonus. You see this in tetanus also. This tonus is followed by rhythmic clonus or clonic seizures. They usually last less than a minute, and then there's a prolonged recovery period called the post-ictal period, where the patient takes anywhere from 10-15 minutes or longer to recover after this. Now, eventually with ECT, we started to use procedural sedation prior to this shock. Let's say a benzodiazepine or eventually propofol or even general anesthesia. So the seizure activity, the brain was still seizing, but the physical seizure activity was not visible. There were cases of people being injured in seizure activity, people having a posterior shoulder dislocation from an induced seizure, falling off of the stretcher, having compression fractures in the thoracolumbar region. All of this is from a medical procedure that we induced on patients. Propofol, by the way, didn't come along until many years later, but propofol really is the ideal procedural sedation. It is white because it's in a lipid excipient, so medical personnel have renamed propofol. We call it milk of amnesia. Chase's story continues, and by the time Chase heard about lobotomies, they were already slipping into disfavor. In fact, the Soviet Union had gone so far as to ban them in 1950. But a neurosurgeon at Columbia Presbyterian Hospital in 1956 performed one on Chase. Chase emerged, he felt, temporarily improved. But before long, his anxieties and depression reappeared. He worked only at odd jobs and then only intermittently. For 10 years, his lawyers contend, Chase sought a physician who would give him another lobotomy. Finally, by calling University of Pennsylvania switchboard, he found Dr. Groff. And Groff performed 2 lobotomies on Chase, one in 1967, another in 1969. Afterwards, as his physical and mental condition grew worse instead of better, his mother took him to see a lawyer. A Temple neuropsychologist who administered a battery of tests to Chase testified that his overall IQ is now 61, a sharp drop-off since 1966, 10 years after the first lobotomy, when it was in the 100 to 115 range, or bright normal. He also said that Chase suffers from pathological inertia. Having gotten started at any type of activity, he can't get stopped, and having gotten stopped, he can't get started. Whenever Chase appears in court, limping, with his right arm hanging lifelessly at his side, the jury of 5 men and 3 women, plus 2 alternatives, watches attentively. He is a thin man, his face unlined by the emotions others experience. The physical scars of his operation are buried under his hairline. A slight facial paralysis gives him a quizzical look. Weight is no longer a problem now that he cannot smell at all and can taste a little. Recently, he said his favorite food was fish, quote, because at least I can taste the tartar sauce, end quote. He went on to discuss the merits of the tartar sauce at several Center City restaurants. There had been a little bit of a dust-up earlier in the trial when back in late October, plaintiff's attorneys had shown up in court with a human brain in a bucket. The late Dr. Groff's lawyer asked, "May I request that this slightly transparent bucket from which the outline of a brain shows be removed from the courtroom as an inflammatory effort on the part of the plaintiff?" "Inflammatory effort to what?" said the defense attorney. "To educate the jury?" The judge later ruled that the brain was inadmissible evidence. On Friday, September 12, 1975, the jury of 5 men and 3 women returned a verdict of not guilty after a 2.5-month trial and nearly 4 hours of deliberation. Dr. Groff had been exonerated posthumously. His videotaped deposition discussed how this was a destructive operation, but he thought it could help, quote, quiet him down, end quote. Groff pointed out that since the surgery, Chase had not been confined to an institution, and that recent examinations had shown that his anxiety and depression were no longer present. I searched through the newspapers and I find nothing about Chase after this date. He went back to Brooklyn with his mother. I have absolutely no idea what happened to them. In 1997, the Robert A. Groff, M.D., Teaching and Research Chair of Neurosurgery was set up by the bequest of Mary E. Groff to honor her brother, the prominent neurosurgeon Robert A. Groff, M.D. A Penn and Perelman School of Medicine alumnus, Dr. Groff chaired the departments of neurosurgery at Graduate Hospital and the Perelman School of Medicine. He was the inaugural holder of the Charles Harrison Frazier Professor of Neurosurgery chair. And now he had a chair named for him. So whatever happened to psychosurgery? It never went away entirely. In the late 1990s, there was a team of investigators at Harvard, headed by neurosurgeon G. Rees Cosgrove, published a technical report that bore the ponderous title Magnetic Resonance Image-Guided Stereotactic Cingulotomy for Intractable Psychiatric Disease. The report's central thesis sounds familiar. Psychiatric disease can be treated by the selective destruction of healthy brain tissue. Now, Discovery Magazine explored this question in a guest article written by a neurosurgeon, and I want to quote this one paragraph because it pretty much sums up the thoughts on psychosurgery. Remember, this is a neurosurgeon writing this. Finding a paper extolling the virtues of psychosurgery in today's medical literature is rather like finding one advocating bloodletting. Modern neurosurgeons destroying normal brain to treat mental illness? To borrow from Samuel Johnson, this is akin to a dog walking on its hind legs. The question is not how well the act can be done, but why it's even attempted. In spite of its elevated reputation, neurosurgery is a crude business, even or especially to a neurosurgeon, and I've been in practice for 10 years. When confronted with an exposed brain at the operating table, I feel as if I'm about to repair a computer with a chainsaw. The living brain has a surreal fragility. Its porcelain surface is laced with delicate arteries that begin as thick cords but quickly branch into finer and finer threads. Looking at the surface of the brain is like looking at a satellite photo of a large city. One immediately senses a function far more complex than what is visible. The idea that a sophisticated derangement in brain function, like obsessive-compulsive disorder, can be cured by frying holes in the frontal lobe looks as patently absurd as recovering a lost file from a floppy disk by burning it with a curling iron. But experience suggests that such lesions can work if they are done correctly and on the right patients. In the 21st century, the focus of neurosurgery for psychiatric purposes is shifting from surgical ablation to deep brain stimulation, DBS, which uses implanted electrodes to treat conditions like OCD and major depression. Two examples still used today. Bilateral cingulotomy. This surgery targets an interior portion of the brain called the anterior cingulate cortex to treat severe treatment-resistant depression or obsessive-compulsive disorder, OCD. Also, stereotactic anterior capsulotomy. This can also be used in people with treatment-resistant OCD. This targets another interior part of the brain called the internal capsule. Radiation or high-frequency sound waves create lesions on the brain to block overactive nerve pathways. Both surgeries are considered a last resort when cognitive behavioral therapy and medications fail to provide relief for someone catastrophically affected by OCD or depression. Dr. Robert A. Groff is gone for 50 years now. He is interred in the West Lawn section at Laurel Hill West Cemetery. I'm going to fade out with a song, the first section of a classic song by the Ramones. I think you can figure out the lyrics. In the August 2025 episode of All Bones Considered, Laurel Hill Stories number 76, it's College Namesakes. We have more than half a dozen people with institutions of higher learning named in their honor. I've already talked about John B. Stetson, founder of Stetson University in Florida, and Eleanor Elkins Widener, namesake for Widener University, in prior podcasts. Now it's time to finally hear about Joseph Wharton, whose donation led to the Wharton School of Business, Charles McAllister, who built the estate Glen Ford on the Delaware River, and donated money and land to establish McAllister College in St. Paul, Minnesota, Joseph Moore Jr., whose $3 million donation in 1932 caused the name change from the Philadelphia School of Design for Women to the Moore College of Art and Design, And I hope there's time for Captain Henry Biddle. He died of wounds received late in the Civil War, and his wife's donation in his name caused the founding of Biddle Memorial Institute, which is now known as Johnson C. Smith University in Charlotte, North Carolina. I plan that August Biographical Bytes from Bala, Laurel Hill West Stories, will be about historian and author Dr. Ellis Paxton Oberholzer and his mother, suffragist, activist, poet, and economist Sarah Louisa Oberholzer. She was responsible for a huge number of American school children establishing savings accounts through their school classrooms. For upcoming activities and tours, go to the website laurelhillphl.com/events. What am I doing in July? Anything? No. I'm not giving any tours. I do have the book coming out, however. It gets closer and closer. I keep saying that every month. I probably said this before, but there's an old adage that in a large job, the first 90% of the job takes 90% of the time. The last 10% takes the other 90% of the time. I'm in the thick of that last 90% right now, trying to get this thing to the finish line. I'm getting there, though. I'm getting there. I'm going to have me a book in hand sometime in the next month or two. All Bones Considered and Biographical Bytes from Bala are mostly research, written, narrated, and produced by me, Joe Lex, a retired professor of emergency medicine from Temple University, volunteer tour guide and podcaster for both cemeteries. You can reach me through my email, jrlexjr1947@gmail.com. Theme song, Names at Peace, is by local artist James Harrow. And maybe I will see you on a tour. Stay safe. Stay well. Bibliography is coming up next, and some good stuff in the bibliography. There's lots of good material on lobotomy. I tried to stick to things that were relevant to the podcast, but I probably wandered outside of my area of interest a little bit. The oldest article I use is called Lobotomy, Surgery for the Insane. That's from Stanford Law Review, April 1949, Volume 1, Number 3, pages 463 to 474, published by Stanford Law Review. No author identified. Then there's an article by Alberta J. Nassi and Stephen I. Abramovitz, From Phrenology to Psychosurgery and Back Again, Biological Studies of Criminality. It's from the American Journal of Orthopsychiatry, Volume 46, Number 4, October 1976, and that runs from pages 591 to 607. Sufficient Promise, John F. Fulton, and the Origins of Psychosurgery, author Jack D. Pressman, Bulletin of the History of Medicine, Spring 1988, Volume 62, Number 1, pages 1 through 22. From an article by Micalraz, that's Micalraz, Between the Ego and the Ice Pick, Psychosurgery, Psychoanalysis, and Psychiatric Discourse. It's from the Bulletin of the History of Medicine, Summer 2008, Volume 82, Number 2, pages 387 to 420. I managed to skim a copy of the book American Lobotomy, A Rhetorical History by Janelle Johnson. That is from, University of Michigan Press, Ann Arbor, 2014, 240 pages. A copy of The Pharaohs, the Penn publication from August of 2016. Nice little 8-page insert on the 20th General Hospital with a lot of photos from Ravden's private collection. I did not see this back when I did the podcast on Ravden. I don't know that it added much to what I already knew, but it was nice to have it all combined in one article. I think that's it. I mean, obviously there were a lot of newspaper articles, especially from 1975. Okay, that's what I got for you for July. Stay safe, stay well, stay above ground.